I think if I have to start this class, no, shut it. So if I have to start this class with upper or lower, upper's easier to me in the sense that the muscles tend to be bigger and more organic. But the articulations and kind of how things get put together seem a bit less simplified than if I was doing the lower. I mean, the lower, I've got the pelvis, and out of the pelvis comes a bone that goes as my femur drops down, it articulates at the knee. And then you throw the whole scapulothoracic articulation in there, and then it just starts scaring me. So that's why we started lower. But with lower, you get into all of that external rotators, a whole series of muscles that you can't touch, you can't push on, you can't deal with, and so then you're like, they just might as well not exist as far as people's preference goes. So we're going to dig into upper because we kind of sort of need to now that we've gone through most of lower. So, bones. Quite simply enough, we're going to start with the axial skeleton because our articulation point is going to be in the chest to begin with. So what's the difference between axial and appendicular skeletons? Which is which? Appendicular is with your appendages. It's pretty much everything outside of your head, neck, and spine. So frequently we kind of include our rib cage in with the axial skeleton as it articulates with the ribs. So at that point we get to where does the sternum sit, and then how does the clavicle come off of that? All right, so yay for this program. So what we have here is a series of bones. Xiphoid process, the tip down here right at the base of your sternum, the sternum itself, and then the manubrium. Now that really kind of focuses and is set with the axial skeleton as well as it helps close off the rib cage, meaning that the clavicle then gets into identifying the first component of our upper appendage. So the only bony landmark, the only ligamentous connection that the entire upper arm has with the axial skeleton is right here. The sternoclavicular ligament. Everything hinges on this joint connecting or the clavicle with the manubrium, the clavicle with the sternum, such that all of this load transfer, all of this force transfer goes directly through this. So if you damage that joint, that ligament, your life is going to be hurting quite a bit. Now on the sternal end, it's a bit broader. It's actually a saddle joint. There's a compression for the costoclavicular ligament, which tethers, which will sit right in through here, tethering this, the clavicle in with the first rib. So you'll find that this isn't a very strong structural in terms of tying it down in place. It's more just a connection piece. We tether it a little bit here, and then we tether it even more strongly with the corticoclavicular ligaments on the other end. So even coming out to the AC joint, where the acromion process of the scapula meets up with the clavicle, this ligament set here, again, isn't very strong in the sense of restricting joint motion. Most of that is done by the anchor tether here and here, which is the corticoclavicular ligament, and there's two parts, the conoid and the trapezoid. So, and as such, you've got the conoid tubercle here and the trapezoid line right here. So those are going to be thickenings, fat parts on the distal end of the clavicle that allow for attachment points for the corpoclavicular ligament. You will see questions asking like an AC sprain where you damage that acromioclavicular ligament. What ligaments are primarily responsible or primarily injured in that? And it's definitely going to be the corpoclaviculars here and not the acromioclaviculars at the end. So just another view. And then in this view here, you can see that costoclavicular tying in that first rib to the clavicle. Anybody outside? All right. In this joint space, there's also an articular disc which helps pad and cushion. Don't know much about injuries to that, but it exists. And then spanning the top is the interclavicular ligament running in between one clavicle to the other, which helps tie it down. As the ribs come into to the notches, to the costal notches, all of those, so it's a cartilaginous endpoint on the rib, which then ties into the bone. So they're called synchondroses. So they're not full articulations with synovial capsules. You can dislocate ribs. It's not a very comfortable thing to do. You can have inflammations of those joints as well. Not very comfortable things to have. But you've got articulations from the first down to the seventh ribs at the xiphoid, just superficial to the superior to the xiphoid process down here. So sternoclavicular, primary supportive structures. You have the anterior, posterior sternoclavicular ligaments. So one in front, one in back. You have an interclavicular ligament that we talked about running across the top here. A costoclavicular ligament which tethers in the clavicle to the first rib with the articular disc. So not too much going on that's tragically difficult to figure out. So if we're going to dislocate this, what do you think a problem is going to be? Which direction are we going to have more of a medical emergency if you dislocate the sternoclavicular joint?
Superior? Like posterior?
Posterior.
Oh, like back.
So if that clavicle gets punched backwards
Oh,
into the thoracic cavity, what are we concerned about?
and the carotid?
Oh, all the stuff that keeps you alive. So when we get into head, neck, and spine, we'll discuss far more anatomy of the neck and through here, but this is where all your soft squishy structures are, right? We'll discuss dislocations of these joints in ortho, but you get the idea. All the soft squishy stuff is underneath. We like to protect that.